Oops.
Yeah.
Okay.
Yeah, sorry,
We
Julie,
can
what were
talk
you saying?
later.
Oh, yeah.
We can talk later, yeah.
Hello.
So
Hi.
there's Osama.
Hello.
Hello.
How's everyone?
Hi,
Hi.
thank you.
Good, good. How about you?
Good, thank you. Who?
You sound a little muted. Or is that me? Better now. When
Share.
you,
Is that better?
what do you think, Mary?
It sounds like, I mean, I can turn the volume up on my mic and that, so I think probably maybe the audience want to say whether or not they think our sound's okay. They're probably better.
Is someone recording this?
It says they are. I saw that. So that,
I was supposed to record it.
Well, somebody has pressed record. It's not me, but somebody has pressed record.
but it also looks like it's a different meeting.
In what way?
Wait, let me get back. Maybe
It
that's
says-
just what.
It seems to be that TUGS, which is you, Osama, is recording.
Okay, yeah,
That's what it says in the participants list.
good.
Ooh.
I'm trying to make everyone.
There's so many different platforms, isn't there?
Yeah.
I noticed Sylvia's joined us. Hi, Sylvia.
Good morning. Hello.
Hi.
Good
Hi,
afternoon.
Sylvia.
Mm.
I gotta get out of here now and back over to you guys. Okay. Here's that like that. I don't want to.
So, Julie, can you try and share your screen, please?
Mm-hmm.
See if that's going to work. I made you
Okay.
a co-host.
Here we go.
Good. So we can see
Okay.
that.
Yeah, brilliant.
Okay, good. You want
And
me to unshare?
yeah, looks good.
Okay.
Sylvia, can you try and share your screen as well, please? Excellent. Good.
Yeah.
Excellent.
Let's decide where my thing
What
needs to
about
go.
Ken? Ken, can you try as well, just in case you want to share your screen at some point?
It's at this point, I wonder, should I have done some slides?
No,
No, I'm not. I've got no slides.
That's fine. That's fine.
Is that okay?
Yeah. Just check.
yeah, I wasn't planning, Ken, that you or Helen did any presentation, because I think we've got 4 already and 4 dietitians, and then with you and Helen being able to widen out the discussion, that'd be great.
So who are we missing?
Helen, Pretty, and Laura, but we're still time yet. So, yeah, and Violeta's to join us.
Yeah. Okay, good. There's quite a few participants already logged on, which is a good sign.
Yeah, and I was just going to take advantage and say hello to my good friend Isabella in Singapore. I've just noticed she's joined. So hi, Isabella.
Hi, Mary. How are you?
I'm fine. And how are you? It's good to see you on this. So yeah, we must have a catch up sometime as well.
Yes, definitely.
So I think, Mary, for the presentations, I'll give kind of a warning at 10 minutes. I'll time the presentation, so we're a bit tight for time. So I'll give a timer at 10 minutes and maybe 13 minutes, and leave a couple of minutes for questions if that's okay. And then we'll move on to the next speaker. How does that sound?
Yeah, that sounds good.
Good.
And are we planning the panel discussion at the end of all the presentations?
Yeah.
Yes, Ken. Hi,
Yeah.
Laura. Hi.
Is Laura on? Violeta's on as well.
Yeah. It's hard keeping tabs on all the
Yeah.
names on the screen, isn't it? Yeah.
Hi, good afternoon, Laura.
Hi.
Can you try and share your screen just for a second, just so we
Yes,
can check that everything
sure.
is okay?
Violeta, your hair looks wonderful.
Hi, thank you. Hi, Julie, Sylvia. It's nice seeing all of you. Hi, Laura.
Hi.
Mary, how are you doing?
I'm fine, thank you.
So and I try to share my screen. Can everybody see it?
Yes.
Yeah, excellent.
Mhm.
Yeah.
Okay, great. Then I will stop sharing.
And Violeta, please.
Yes. Let me do that. So I think this have to be compartir. Okay.
Good, great.
So yes. Okay. Let me go back. Okay. Okay. So good.
Good. Everything seems to be working.
So is the audience watching us the picture while we are speaking or just the screen?
What's that? Sorry, say again.
Can they see us while we are presenting, or they are going to see just the screen, the presentation?
Yeah, just the screen share.
So we are not in a square there,
You should,
like
No.
yeah, your picture should probably when you're
a little
presenting
bit.
Violeta,
Okay.
yeah, we'll turn off our cameras, Violeta, and then you should still be visible
Okay.
as a speaker. Yeah.
Okay, good.
Yeah. I think Helen's, I can't see Helen, but it looks like she's joined us.
I am here.
Good. Yeah.
My camera's on. I'm just going to blur my background so people can't see my son's clothes.
Yeah.
Hang up behind me.
What I had to do. No looking to see the ground here.
Hi, Helen.
Oh,
Hiya, how are you?
Wet and windy here.
Yeah, I've just been at rugby watching my son, had to leave early, so it was very, very windy there. Yeah. Right.
So I was saying to Mary, for the speakers, I'll give you a kind of a timer at 10 minutes and 13 minutes just to finalize and finish off. So we can have a couple of minutes of questions and then move on to the next speaker. Is that okay with everyone? Good.
Helen, dare I ask what happened in your Zoom meeting the other day then?
Oh God. I was trying to work out, my sound's really quiet. I don't know whether it's me getting old. Quite possibly. So I was giving a talk on Friday for one of our institutions at UEA on bariatric surgery, and we got Zoom bombed. So somebody started taking over my slides, moving my slides around. So we had to shut it down before patient got to speak and before the second speaker got to talk. So
gosh, they actually took control.
Yeah, they took control, and worrying they actually changed one of my slides. Not much, but yeah, it was a bit new experience, not one I've had before. But there was just like a little bit of noise in the background. But I thought it was just people joining early and they remembered to put their microphones off.
Yeah.
And then there was a thing popped up on my screen saying somebody was trying to share my screen or take over control. So I said no a few times, but I was speaking, so sort of trying to focus on what I was doing. So then ignored it, and then somebody took over control and was sort of just going backwards and forwards through them. And we just shut it down.
Gosh.
Yeah, it was a weird experience.
That sounds like, wow.
Yes. I think I'm about to have to turn my volume up. Yay. Mary, can you say something for me?
Hi, Helen. It's well since I've seen you.
I can hear you properly.
We are really, really hoping that if so goes ahead this year and is face to face. So,
But hopefully 2022, right?
yeah.
Yes.
Makes it a lot easier when we've been vaccinated, doesn't it? So, yeah.
Yeah, I had an abstract accepted that I was going to present, and so now we're trying to get that into publication, but I did come up with another idea.
Oh, good.
Actually based on this talk, so.
Oh, good.
Do I have just 1 minute? I'm going to
Yeah. Oh, yeah. Yeah.
fill my water real quick. Be right back.
No, it's fine. Yeah. I think people are obviously still joining, and I think that a lot of people are looking, if they can't join, are looking forward to seeing it on catch up as well, because it's been lots of requests about it. It's obviously very, very topical. Yeah.
I will send the recording. We'll upload it on YouTube, and I'll share the link with everyone once it's uploaded. So we'll wait just a couple more minutes, and then we can make a start, I think. Okay, I think we're gonna make a start, guys. It's 2 minutes early, but I guess people will keep logging in, hopefully. So thanks very much for logging in on your Sundays. A big thanks to the speakers as well for logging in. This is our third TUGS bariatric event, and it's based on nutrition and supplementation after bariatric surgery. We have an excellent program today from specialists from nearly every continent. My name is Osama Musa. I trained and specialized in bariatric surgery in Northwest London and completed my research at Imperial in trends in obesity in the UK. Co-moderating with me is Dr. Mary O'Kane, who's a national figure and has been a member of national committees, including NICE Obesity. She led the development of the BOMS nutritional guidelines and the UK follow-up guidelines for patients undergoing bariatric surgery. So without any more delays, because we have a busy schedule today, we have 4 excellent speakers. The first topic is the role of protein supplements after bariatric surgery by Violeta Moize. Violeta is a clinical and research dietitian-nutritionist in the Hospital Clinic Barcelona. She completed a Bachelor of Food Science and Technology and a Master's in Food Design and Innovation. And she's currently an associate professor in the Faculty of Medicine. Violeta, the forum is yours.
Thank you very much for inviting me. I am so happy to be here and share this beautiful webinar with all of you. So I am assuming you are all seeing my screen properly now. So the role of protein supplementation after bariatric surgery has been extensively considered lately and since the beginning of the bariatric surgery. So as it will see, we will be comment further later in the webinar. The anatomical changes after bariatric surgery compromised vitamin, mineral, and protein status. Actually, the changes in eating behaviors and meal patterns also are responsible for this risk situation. And this is even more important for malabsorptive procedures, so the larger the segment of the intestine that has been bypassed, the larger is the risk. The role of this protein intake, dietary protein intake along the process has been emphasized also in the literature, as I said before, because this sustained negative energy balance affects protein intake, and this makes difficult for our patients to reach the protein goal as stated in guidelines of about 60 grams a day minimum or 1.2 grams by ideal body weight a day for the mixed procedures. But also protein intake has been related to malnutrition, and somehow it can affect all the components that regulate the homeostasis of the body, because it is related with lean tissue mass retention during weight loss, also with satiety and thermogenesis. So in some way, the protein can potentially interact with weight loss and weight regain by affecting all these systems. But protein intake has also negatively associated with glucose homeostasis, since it can be impaired by elevated circulating levels of branched chain amino acids. So sustained periods of negative energy balance decrease body mass due to losses of both fat mass and fat-free mass, being these the principal component of the skeletal muscle mass. So the decrease in the skeletal muscle mass is associated with a myriad of negative consequences, including suppresses the muscle metabolic rate and protein turnover, and this can also down-regulate the metabolic process. So these situations led to an imbalanced rate of protein synthesis and breakdown, since this catabolic in nature state increase the whole body proteolysis, amino acid oxidation, and also nitrogen excretion. However, the underlying mechanisms of physiological mechanisms contributing to this loss of skeletal mass during energy deprivation are not very well described, but the catabolic nature of the negative energy balance and the protective effect of protein intakes were also demonstrated in many studies. So recently it was shown that consuming dietary protein at levels over the RDA above 0.8 grams by ideal body weight a day positively contribute to the system, increasing the protein synthesis and decreasing the breakdown. However, the exact amount of dietary protein needed to optimize this situation hasn't been defined, and protein recommendation after bariatric surgeries still need to be established. So insufficient protein intake, as we said, may compromise many of the related systems in the body, and specifically it can affect the outcome of bariatric surgery, since it might, as we said before, downregulate the metabolic process and compromise weight management. Indeed, the loss of skeletal muscle during weight loss induced by bariatric surgery is a consistent and desirable observation due to the negative impact on the integrity of the skeletal muscle and preserving also the functional capacity in aging. So it has been also related with sarcopenia, and it should be prevented and treated. So regarding the changes in body compositions and energy metabolism, I want to show you this study that shows how body fat and lean tissue change during the first year after bariatric surgery. But lean tissue at 6 months is significantly different, is the moment that must change. And beyond this point, it remains stable. This was done in 29 subjects, but interestingly, in a subsample of 12 individuals that underwent whole body calorimeter, total energy expenditure and sleeping energy expenditure also significantly decreased at 6 months and not beyond that. So changes in both fat-free mass and fat mass had an effect on the reduction of sleeping energy expenditure of about 600 calories a day, showing the downregulation of the metabolic process that could compromise weight management. So we were interested to explore if protein intake was related to this lean tissue mass retention during weight loss, and performed this observational study with 50 individuals, 25 going to gastric bypass and 25 sleeve gastrectomy. We supplied them with protein during all the process. We always do as part of the healthcare system. And we observed a relationship between daily protein intake and lean tissue mass loss relative to weight loss at 12 months after gastric bypass and sleeve gastrectomy. So as higher the protein intake was, but more lean tissue mass retention was accounting during this process. So the association was significant for gastric bypass. However, for patients undergoing sleeve gastrectomies, the relationship was marginal. So multilinear regression analysis showed that protein intake was one of the determinants of lean tissue mass loss relative to weight loss at 4 and 12 months after surgery. Regarding the type of surgery, only gastric bypass at 12 months were the only independent predictor of the percentage of loss of fat-free mass. And we know that dietary protein intake after bariatric surgery is a challenge. This review shows how the percentage of participants that are not reaching the goal of minimum 60 grams a day is very high. So at 3 months, around 85% of participants do not reach that goal. And that is similar during the whole period. So a lot of patients eat less than even 60 grams a day during mostly the first year after bariatric surgery. So we wanted to explore if protein supplementation could help to achieve this goal. So time ago, we also performed this observational study with 100 participants that we also follow up for 12 months. We also gave them protein supplementations during the whole period. And we did see that protein supplementation helped to reach the protein intake goal. As shown in this graph, percentage of patients reaching the goal for both the more than 60 grams a day, or even the most high one, 1.2 grams by ideal body weight a day, was higher. I mean, the percentage of patients that reached that goal was higher in those who reported to adhere to protein supplementation, and are illustrated here in the white bars. At the beginning of the talk, we also mentioned that protein intake could also have a role in the management, in the dietary management of weight regain. The ideal nutritional approach for weight regain also remains unclear. This study assessed the effect of hypocaloric diet with or without whey protein supplementations on weight loss, body composition, and also resting energy expenditure. This was done in women regaining at least 5% of their weight at nadir during more than 12 to 4 months after bariatric surgery, so long time after the procedure. What they saw is that after 8 and 16 weeks of treatment, the intervention group showed better results in terms of weight loss and fat mass loss, and no changes were observed in fat-free mass as compared to controls, and neither in resting energy expenditure. So we know that amino acids, dietary protein, and physical activity influence muscle mass development in humans. Sustaining certain muscle level needs a balance between the rates of muscle synthesis and breakdown. So with increasing protein ingestion, muscle protein synthesis increases fast, but reaches a plateau at approximately 20 grams of high quality proteins. In contrast, muscle protein breakdown are hypothesized to decrease slightly but continuously with increasing protein or amino acid intakes. Therefore, the net muscle protein balance can possibly benefit from an even greater protein intake that known to stimulate muscle protein synthesis at the maximum. So current evidence suggests that a reduced rate of protein synthesis is implicated in the loss of muscle mass, of course, after gastric bypass. This is not surprising given less than optimal intake of protein that is obvious. We see every day in the intervention observed after bariatric surgery, and because unlike other macronutrients, we have to take into account that protein and amino acids are not stored in the body. So based on not bariatric patients, the focus on elevated intake of branched chain amino acids during negative energy balance is mandatory, since it supports gluconeogenesis, also maintain the whole body and muscle protein synthesis, and also attenuate nitrogen excretion and whole body and muscle proteolysis. So leucine is a potent independent stimulator. However, although leucine is able to initiate the whole process, the other essential amino acids are probably necessary to sustain the synthesis response following protein intake. So at this point, we should consider in this idea of Dietitian published in 2013 that I specifically recommend, since it's very clarified how everything works. The 25 to 30 grams of protein a meal is important to include in 4 or 5 meals a day, containing 3 grams of leucine a meal 4 times a day. Also including 8 to 10 grams of essential amino acids, which is a little above of the RDI, and also distributing this in regular meals during the day. Regarding leucine, we have to consider that it's present in a high variety of foods. Animal foods are the main source, specifically isolated whey protein. We also have to consider that digestibility matters, and animal-based proteins consistently demonstrate that have a higher digestibility rate, higher than 90%, whereas proteins from the best plant-based sources, legumes and grains, show a digestibility rate lower of about 60 to 80%. So as per conclusions from a nutritional perspective, negative energy balance and dietary protein are important regulators of lean tissue mass changes after bariatric surgery, and particularly important during the first 6 months. Also, excessive lean tissue mass loss is undesirable due to its impact that is negative on the metabolic process. Also, protein supplementation plays an important role on preserving lean tissue mass retention and potentially emphasizing muscular synthesis rate. Hypocaloric diet containing whey protein supplementation, although limited, was evidenced in the literature and as a possible option on the dietary management of weight regain after bariatric surgery. And also important, we need more research, more investigation designed to examine the impact of prolonged and severe energy restriction on skeletal muscle protein turnover and the integrity of skeletal muscle and preservation of functional capacity in aging after bariatric surgery that I couldn't include since the limited time, but is also very important and related when talking about protein intake. And with this, I finished. Thank you very much for your attention.
Thank you, Violeta. Great presentation. We have a couple of quick questions that we can take. We're a bit tight for time, but I think this has been mentioned twice. Is there a difference in lean mass loss between patients undergoing bariatric surgery with or without intestinal bypass? So is there a difference between sleeves and bypasses? And did the bypass patients receive greater protein supplementation?
We couldn't demonstrate that there is a difference. So I would say no with the evidence so far available, not us, the rest of the evidence. I think our difference wasn't significant for sleeve gastrectomy because we have just a few subjects. We needed a bigger sample to be able to demonstrate that, but I would say no so far.
Thank you. And another question, please, Violeta. Are there any longer follow-up studies that you're aware of? What's the longest follow-up study?
Well, the longest is 1 year. Actually, we are 1 year with including supplements. It's very difficult. You all agree with me that it's very difficult to keep not only the real methodology that we need to isotope tracer studies that shows the muscle protein synthesis, and these are all short term, first 3 months after surgery. So depending of the methodology, but up to 1 year you can find with body comp methodology like DEXA or something good, 1 year the maximum of intervention.
Okay, thanks very much again, Violeta. Thanks for a
Thank
great
you.
presentation. Next, we have hematological monitoring after bariatric surgery. Are we doing too much? This will be presented by Dr. Julie Parrott. She specializes in registered dietitian nutritional professional in the US and has over 22 years of experience in the field of medicine. Julie is the first author of the ASMBS Integrated Health Nutritional Guidelines. Julie, over to you.
Okay, well, thank you so much for inviting me to speak. I will be talking on hematological monitoring and metabolic and bariatric surgery, otherwise known as MBS, throughout this presentation. So, are we doing too much? Oh boy. Hold on. So, what is hematological monitoring? It consists of labs, biochemical tests, also known to patients as blood work. So why? To assess nutrition status. When? Both pre-op and post-op. So we have here clinical practice guidelines, also I'll refer to as CPGs, that have rigorous methodology and do focus on micronutrient supplementation and recommendations. So on the first column on the left are the different nutrients. Second column are the different types of MBS, or metabolic bariatric surgery. So you can see below the line, most of the procedures that affect those nutrients are malabsorptive, whereas above the line, malabsorptive and some type of restrictive, more specifically the sleeve. So we also have a distinction between pre-op and post-op recommendations with a comparison between 2 CPGs from the US and 1 from the UK. So the green shaded cells and the yellow shaded cells are a recommendation to either, yes, do screen routinely, both before and or after surgery. And the lighter colors are going to be either yes or no, but with some type of caveat, such as with signs and symptoms only, or risk factors, or maybe even just screen at least annually. So if a nutrient screening was not recommended pre-op, then there typically was some type of recommendation for preventative supplementation and or post-op screening. So what I'd like to do is take iron and use that as a nutrient to try to address the question of, are we doing too much? So why? Why are we doing any type of monitoring? Well, there are many micronutrient deficiencies reported, especially in those 3 CPGs. And we can see here with the shaded colored bars, those represent preoperative prevalence, whereas the patterned bars represent postoperative prevalence. Of note, the orange colored bars, these nutrient deficiencies tend to create serious harm for patients, whereas the red, such as thiamine, can produce permanent and irreversible damage. So once again, let's take iron and walk that through. So what is iron and what does an iron deficiency do? Well, first, iron deficiency, ID, and iron deficiency anemia, also known as IDA, are terms that are typically used interchangeably, but they are not the same. Iron deficiency, or ID, is a lack of iron. Anemia is a lack of hemoglobin. So iron is involved in many more functions than just red blood cell formation. Oxygen transport, electron transfer, gene regulation, synthesis of cofactors and enzymes necessary for many metabolic processes, and more importantly, with our COVID epidemic, a fully functioning immune system. So how about diagnosing iron deficiency with symptoms? Well, first and foremost, for many micronutrient deficiencies, fatigue. Also with iron deficiency. Well, that's a difficult thing to use for a nutrient diagnosis. So in ID, also skin can become dry with rust patches. Hair might be dry, damaged, thinning. We might see spoon-shaped nails and possibly some vertical ridges. And we might even see flattened papilla on the tongue, so an atrophic glossitis, and potentially cracked and peeling lips. But overall, what's important to us is the fact that this can decrease our patients' cognitive performance, so maybe like a brain fog, and decrease their ability to exercise. So how do we diagnose iron deficiency? So we have our older method, which actually uses ferritin with the cutoff criteria of 12 to 15. Anything less than that indicates iron deficiency, and anything outside of that is pretty much normal levels of iron. A transsaturation or TSAT above 50 typically represented iron overload, but we will not be talking about that. Our focus is really on deficiency. So with newer methods, newer research, we have the same use of ferritin, but now that cutoff criteria has increased to less than 30. And even more than that, for our particular population, patients with MBS, ferritin less than 100 can also indicate iron deficiency, but more specifically with this chronic inflammation that we know occurs with obesity. Also, functional iron deficiency, whereas the body has the iron, but it's sequestered in different cells, and so unable to be used by the different tissues and cells that need it. The criteria would be a ferritin between 100 and 300, as well as the TSAT less than 20. But we also have more recent global recommendations from the World Health Organization in 2020. So ID with inflammation, you would need a CRP greater than 5, and then you could use a ferritin less than 70 to indicate iron deficiency. So when do we do this and why do we do this? Well, just keep in mind, early symptoms of nutrient deficiencies are fatigue. Pre-op, we want to identify and treat deficiencies. Post-op, of course, monitor the effectiveness of the supplements that we recommend. We want to identify and treat continued or even de novo deficiencies. And over time, we also know that additional symptoms will develop if the deficiency is not treated. So patients may be unable to perform daily tasks, much less daily activity, or even the focus, the motivation to make the healthy choices and lifestyle changes. Long term, we might see decreased weight loss, increased risk of weight regain, and poor quality of life. This could mean that increased fatigue with additional symptoms leads to decreased success and outcomes for both the patient and our program. So is the screening for nutrient deficiencies working? Well, we saw earlier in those clinical practice guidelines that there was a recommendation both pre and post, and primarily it was to, yes, routine screen. However, either programs are not doing the screening or maybe not using the criteria, we still are having deficiencies and surgery is still being done before some of the screening. So after surgery, we tend to have signs and symptoms and then an action of screening. This would be considered a reactive model, so maybe not the ideal. So let's take a simple thought experiment, cost of testing and not testing. Maybe cost is the deterrent. So again, we use that newer method to diagnose ferritin and or TSAT. So in the US, ferritin costs about $14, but with using only ferritin and that cutoff criteria 30, we could be missing an additional 30% of patients with iron deficiency as presented by Benodi and their most recent study 2021. Thus, IDI, we add ferritin and or TSAT with an additional cost of about $15, which comes to almost $30 in the US. But if we add an additional $5 for the CRP, which is to create a little bit more sensitivity to detection of iron deficiency, it would be about $34. So let's look at the cost to the patient. The median wage in the US per hour is $19.33. But we have a couple of unknowns when looking at this. First, how severe is the deficiency? And second, how often is the deficiency missed? So in order to look at the severity, we're going to vary the number of days patients are sick from work in a year. So from 1 day, 3 days, 5 to 7. And then how often is the deficiency missed? So we can vary the proportion of patients that have a missed, not misdiagnosis, but missed between 10 and 90%. Could be because lab results aren't available, maybe there's no screening, or maybe the wrong lab assay and or result criteria were used. But our main and underlying assumption is that if patients had been tested, then all patients with iron deficiency would be diagnosed. Yes, this is ideal, I know. So what does this look like for 100,000 patients with MBS? So if we look only at the lost wages and ignore the direct and indirect medical costs for treatments that could have been prevented, such as their loss in quality of life, how does this annual cost of universal lab testing for ID compare with the annual loss of income for 100,000 patients? So first we'll look at the annual cost of testing, which is this blue line that goes across the bar graph. And that's about $2.5 million to screen every single 100,000 patients. But if we look at the proportion of patients, you see the percentages on that x-axis. We varied between 10% of the patients missed in a diagnosis and all the way up to 90%. And we've also varied, again, the number of unhealthy days that a patient might miss from work. But keep in mind, that's on a yearly basis. So we have in green, 1 unhealthy day, blue is 3, orange is 5, and purple is 7. So at the very top, we do see that escalating costs based on severity of deficiency and difficulty diagnosing is happening. So for deficiencies that are severe and difficult to diagnose, the annual cost is about 30 to 35 times higher than universal testing. So not testing only makes sense when the deficiency is easy to diagnose from signs and symptoms, which we just showed that ID is not one of those, and it does not have severe health impacts. So what do we know? So what is known? Many patients have nutrient deficiencies both before and after surgery. Nutrient deficiencies do not get better. We all know that after surgery. When should the patients be screened or tested? Patients need to be treated for deficiencies pre-op, and they need to be monitored to prevent and treat deficiencies post-op. So overall, patients do need to be screened both pre and post-op. So let's look at that model. What if we do screen and we recognize problems, maybe just by signs and symptoms, but maybe using the diagnostic lab? So then we can actually treat patients' nutrient deficiencies before they have surgery. This is a proactive model, which is ideal. So I have questions to the questions of, are we doing too much? Are we doing too much post-op? Are we doing too little pre-op? And are we doing too much too late? So food for thought. Why are we waiting to treat patients for nutrient deficiencies until after surgery? Thank you. Okay.
Thank you very much, Julie. That's very interesting.
Oh, you're welcome. Let me try and get
no immediate questions from the chat and the forum. So
I think there was one. There was what morbidity may be caused post-op with iron deficiency anemia.
I'm sorry, what was the question?
What morbidity may be caused immediately post-op with iron deficiency anemia?
What medical? I'm sorry, Mary.
Sorry, it's my accent.
Are you wanting to diagnose? Yeah. Are you wanting?
Yeah. Well, so with iron deficiency anemia, what immediate post-op issues might that cause?
Well, there definitely, especially if it's iron deficiency anemia. I mean, I mentioned that there can be all different types of anemia, and if iron is one of those, then definitely we're going to see some of those very same symptoms, because anemia caused by iron is going to go through a depletion of all of the iron essentially in the body, and then we're going to see changes in the hemoglobin levels. So we are going to see symptoms that would be symptoms of anemia, not having oxygen, oxygenating the body and getting to all the different cells. Did that answer the question?
Yeah, thanks. And I've got one quick question of my own, which won't surprise you, Julie. Just with doing the guidelines, as you know, is that we can only go on the evidence that's there. And the thing I struggle with is with some of the procedures, especially the malabsorptive procedures, they just don't measure the fat soluble vitamins and the trace minerals afterwards. So how do we know that there isn't an issue? So, because I've been told sometimes that such an operation is okay, we don't see the same problems with have the jejunal switch. But when I actually look, literature, the studies haven't measured them.
Right. There are a lot of gaps in the literature and the research, as we all know. And that would be one of them. And I guess the way I look at it is the severity of the deficiency. And sometimes, you know, I kind of presented an ideal world, but yet even when it's not ideal, to compare, you know, the cost again of not measuring versus what that, you know, not testing a patient is going to do, not only to just them missing work, but think about it. We've all had patients who say, oh my gosh, I'm so tired, I can't even get out of bed. You know, if that happens pre-op, think about the potential for blood clots. I mean, there is such huge ramifications, and that's why I did choose iron in particular. But to answer your question about fat-soluble vitamin deficiencies, I mean, I do think we have to prioritize, and I do think we need more research looking at especially the more recent surgeries that do have that malabsorptive component, because there's a high potential for there to be deficiencies. And of course, those deficiencies are what? They're going to impact patients, they're going to impact the outcomes, their quality of life, as well as our bottom line, the program outcomes, even potentially surgeon outcomes. So,
some more questions coming up, Julie, but I'm thinking that we probably can pick some of those up in discussion,
okay.
But especially because we've got Ken representing Obesity UK and Big Patient Forum, and also Helen Peretti, GP as well. And I'd really like to bring them into the discussion about some of the issues that are being raised. So,
great, thank you.
Yeah, thank you.
Thanks again, Julie. So carrying on with testing and supplementation, Laura Heusschen is going to talk to us about why do some patients not receive or take the supplements they need. Laura is trained as a nutritionist and dietitian. She finished her bachelor's and master's degree in nutrition and health and is currently a Ph.D. student. Her research focuses on nutritional consequences of bariatric surgery. Laura.
Yes, thank you for the introduction. Let me share my screen. Yes, so I will focus on why do some patients not take the supplements they need. So I think that many of us know that all patients who undergo bariatric surgery are at an increased risk of developing nutrient deficiencies. And this might be a combination of pre-existing deficiencies, decreased post-operative intake, and also the reduced absorption after surgery. So therefore, patients are advised lifelong micronutrient supplementation. However, we know from clinical practice as well as from research that adherence to these recommendations can be poor. And poor adherence to supplementation is associated with higher risk of nutrient deficiencies. And this can result in complications, as we saw in the previous talk, such as anemia or even bone loss or neurological problems. So it is really important to understand the reasons behind poor adherence with post-bariatric surgery nutritional supplementation guidelines. So actually, there are very few studies that attempted to understand the factors associated with poor adherence and compliance with micronutrient supplementation. And one example that might seem familiar to you is this paper from our UK colleagues. The most important report reason in this UK survey was difficulty in remembering, too many tablets, side effects associated with the supplementation, high cost, and also non-prescribing by the GP, bad taste, and not feeling the need to take them. So we performed a similar patient survey study in the Dutch population, together with Marieke Smelts on the left, who was the initiator of the study. So what we did is we included patients who underwent bariatric surgery from 2015 to 2020 in one of the participating centers. And we included all types of procedures, so also revisional procedures or secondary procedures. And in total, more than 15,000 patients were recruited, of which more than 4,000 600 patients were included in the analysis. So what we did is we conducted an anonymous cross-sectional survey, a non-validated survey, with questions that were divided into 4 topics. So we had the patient-related factors, the multivitamin supplementation related factors, psychosocial and economic related factors, and also the healthcare related factors. And I will discuss them one by one. So first of all the 4,614 patients that were included, 93% indicated to use a multivitamin supplement. And of these, the majority reported to use a specialized weight loss supplement. And the other 14% used a regular over-the-counter supplement. So when we compared the users of supplementation on the left with the non-users of supplementation on the right, we did not see a difference in gender as in the UK survey, in which males were more likely to report complete compliance. We did see that non-users were in general younger and also more often underwent the gastric sleeve. So yeah, we thought about this, and I think this could also be due to the fact that still some people, patients, but also healthcare practitioners, they feel that the gastric sleeve has minimal impact on nutritional status and a less risk of developing nutrient deficiencies, which could declare this finding. So with respect to the time since surgery, we can see that the surgical procedure was more recent for the non-users. Yeah, it is plausible that adherence to supplement intake is better in the first post-operative year due to the intensive follow-up compared to multiple years after surgery, when most patients are often no longer supervised by the medical team. So, so far I only talked about users and non-users of supplementation. However, within the group of users of multivitamin supplementation, some patients also reported that they not use their supplements consistently every day. This was about 17% in our survey. And interestingly, when we compared reported reasons for inconsistent use to the reasons reported by non-users, these were actually different. So we see the reasons reported by inconsistent users in blue and the reasons reported by non-users in gray. And you can see that for the inconsistent users, the most important reason was simply forgetting the intake. So a part of the patients also experienced difficulties with scheduling their daily intake because of interactions with, for example, the calcium and vitamin D supplements or other medication. On the other hand, non-users reported gastrointestinal side effects and also the high costs as most important. And interestingly, about 20% of the non-users also believe that they don't require any supplementation, as their lab results were good and they felt physically fit. So for all patients who reported gastrointestinal side effects as a barrier, we also asked which complaints they suffered the most from, and that were nausea, excessive belching and hiccups, vomiting, difficulties with swallowing, and reflux. And interestingly, only 60% was free of complaints after stopping of the supplement intake. So we also found that the non-users experienced more of these gastrointestinal complaints in general, so irrespective of the supplementation use. This could also explain the high percentage of these side effects we found in this non-user population. So then with respect to the psychosocial factors, we found that poor motivation was an important factor in non-users. About 70% was not motivated for daily multivitamin intake compared to 10% of the users. And most reported reasons for non-motivation were having good blood tests. They had no complaints, so no physical complaints of the deficiencies, and the unpleasant smell, taste, and or size of the supplement. So what we also found was a lack of knowledge in the patients participating in our survey. When we asked all patients whether they thought if the use of multivitamin supplementation lowers the risk of nutrient deficiencies. A quarter of the patients, of the non-users, answered no. So this could also indicate a lack of patient education. So then for the economic related factors, the price of multivitamin supplementation was perceived as a barrier, so the high cost. Most of the users think that the price is acceptable, about 60%, whereas the opposite was found for the non-users. So in this group, about 60% finds the cost too high, and 45% indicate that reimbursement of supplements would improve their adherence. So what was interesting is that in a recent study of Heusschen, he showed that specialized supplementation actually leads to lower costs. So we saw that many patients experience the high cost of supplementation as a barrier. And that is also one of the reasons why they switch from the specialized supplementation to, for example, the over-the-counter supplementation, which are often much cheaper than the specialized supplementation. However, in this paper, Heusschen showed that the costs for standard multivitamin supplementation, so over-the-counter supplementation, is about 300 euros every 3 months, whereas this is only 200 euros every 3 months for the specialized multivitamin supplementation. So in the end, the use of specialized supplementation, so the blue one, actually leads to lower costs than using non-specialized over-the-counter supplementation. So then we were also quite curious to the healthcare related factors. And we found that non-users were more often dissatisfied about information regarding importance and instructions of the multivitamin use. Also the attention paid to multivitamin supplement use during medical consultation, and the extent to which personal preferences of multivitamin use are taken into account. So most frequent reasons for scoring poor or inadequate on one of these subscales were that the information on supplementation was too general, that there was not enough time during the consultation to discuss supplement intake, and that personal preferences were not taken into account. So some patients also mentioned that the hospital or the doctor only recommended one type of supplement or one brand of supplement. And when they experienced complaints from this specific type of supplement, they didn't provide any alternatives to the patients. So in general, what most patients missed when taking education information about supplementation into account were information about the side effects and also the disadvantages and benefits of supplementation, about when and how to take their supplements. And as I mentioned before, also alternative options when they were not satisfied with the advised brand and what they could do in case of complaints or side effects. So we found similar barriers as reported in the UK survey. Most important ones were gastrointestinal side effects, unpleasant smell, taste, size of the supplements, high cost, and also the dissatisfaction with the medical consultations. So, and then especially the time and attention that is paid to multivitamin use in this case. So next to within the patients themselves, of course, challenges lie within 3 different parties. So we have the supplier of the or the manufacturer of the supplementation. We have the insurance companies, and we have the healthcare professionals. So for the gastrointestinal side effects and the unpleasant smell and taste and size of the supplement, these could be improved by optimizing the multivitamin supplements. However, this is quite a challenge because next to an ideal combination of taste, smell, and size, supplements must primarily ensure adequate absorption. Also, many regular supplements, so the over-the-counter supplements, have special coatings that reduce the unpleasant aftertaste that many patients suffer from. However, this type of coating is not really desirable for our patient population due to the decreased bioavailability. So optimizing the supplements remains a challenge. So then the high cost. Yeah, well, the most obvious solution is to let insurance companies reimburse costs for supplementation. And for example, by only reimbursing specialized multivitamin supplementation with proven effectiveness, we could also motivate patients to choose these supplements instead of using regular over-the-counter ones. However, I don't think that this will happen in the near future, at least not in the Netherlands. So for this barrier, there's also a role for better instruction, patient education, because patients often believe that the costs do not outweigh the benefits of specialized multivitamin supplementation. Well, that is not the case. So patients should be educated about this and also be informed of the additional financial burden prior to surgery. So then lastly, the dissatisfaction with medical consultations. Well, a third of the patients were dissatisfied with the attention that is paid to multivitamin use. So they found that information was too general or that personal preferences were not taken into account. And they also indicated that healthcare professionals often recommended only one type or brand, and patients therefore cannot choose which supplement suits their preferences. So next to giving more detailed information, also instructions about multivitamin use to improve patient knowledge, healthcare professionals could also improve the relationship with their patients by implementing shared decision-making. So in briefly, shared decision-making involves that the patient's preferences become a more important part during the medical consultation. And this could improve their motivation and adherence to the supplementation. So our study provided some valuable information about which factors, at least in the Dutch population, are important for patient adherence. But of course, there are also questions that still remain unanswered. So future research could, for example, further explore which specific patient groups have a high risk of non-adherence. If there is a difference in adherence after primary and secondary or revisional surgery, as we included all of them in our survey. It would also be interesting to investigate whether patients who are not compliant indeed have more nutrient deficiencies, which we would expect. And lastly, we would like to see what healthcare professionals think about their professional relationship with their patients. If from the healthcare professionals' perspective, if they believe that they spend enough time to information on multivitamin supplementation, for example, and to see if these two perspectives are in line with each other. So thank you for taking the time to listen to this presentation. Are there any questions?
Thanks very much, Laura. That was very interesting, very good presentation. I think we're running a bit late on time, so maybe take the questions in the expert panel at the end. So we'll move straight to the next presentation.
Sure.
Does gut microbiota have a role in weight loss maintenance after bariatric surgery? By Silvia Leite-Faria. She's a postdoctoral Ph.D. in human nutrition from University of Brazil. With over 21 years of experience, she also has been a national and international speaker for several years and already published extensively on nutrition in bariatric surgery. Welcome, Silvia.
Thank you, doctor. Thank you for the invitation. I'm glad to be here. And I'm going to talk about microbiota and the role of microbiota in the weight loss and weight maintenance after bariatric surgery. I have no disclosures. And we have actually more bacteria in our body than cells. We have near 2 kilograms of bacteria in our gastrointestinal tract. And most of our bacteria are from the genera Firmicutes and Bacteroidetes. We also have Enterococcus, Proteobacteria as other genders of bacteria in our gastrointestinal tract. Now talking about our microbiota and a metabolic profile, studies have shown that lean population, they present a high diversity microbial gene richness and also a high gene count. By other way, this population, they present low diversity, microbial gene richness and low gene count. And this profile of this population in terms of low gene count and diversity, they will have an impact in leading to lower satiety, increased lipogenesis, increased inflammation, increased gut permeability, increased fat accumulation, increased inflammation, and decreased fat oxidation. And all of these can lead patients to some disease, such as cardiovascular diseases, liver diseases, diabetes, and so far. Well, four most important points are make this correlation between obesity and microbial gene richness. Depending on the genera of a species of bacteria you have in your gastrointestinal tract, the bacteria are going to be better or more able or not to deliver energy. They will have an impact in insulin resistance. They will have an impact in fat storage and lipid metabolism, and also inflammation. So these four important points will make the correlation between microbiota and metabolism. Well, talking about changes in the gut microbiota, we know that some points we cannot change in our microbiota. So our genetics, the host genetics profile cannot be changed. The mode of birth has an impact on microbiota and we cannot change that. However, some environment factors can have an impact on microbiota, and we can deal with that, such as exercises, diet. Actually, diet is responsible for more than a half of our microbiota richness. Also smoking and medication, alcohol consumption, stress have an impact in our gut microbiota. And I will talk now about bariatric surgery. We know that bariatric surgery is the best treatment for severe obesity, and we have five important alterations that have an impact on patients' gut profile. We have the BRAVE effect, called by this paper, and BRAVE is the abbreviation of these five alterations in patients' gastrointestinal tract. So bioflow alteration, reduction of gastric size, anatomical rearrangement, vagal manipulation, enteric hormone modulation, all of these working together, they will lead to some metabolic effects and also obesity decrease. All of the procedures will lead to some microbiota change by some way. And the main causes for change in microbiota after bariatric surgery are related to reduced energy intake, exposure of the gut wall to food, and the time of exposure is also important, and difference in pH distribution, and also the contact with some production or with bioacids. This recent paper have shown that have evaluated patients for 5 years, and they the authors have shown that there is a increased microbial gene richness after bariatric surgery among patients submitted to renal gastric bypass and adjustable gastric banding. And this microbial gene richness is going to continue to be higher with 5 years of surgery. We have three important factors that have an impact on patients' gastrointestinal tract and microbiota. We have changes in the alimentary limb remodeling that will increase secretion, for example, of GLP-1. We have the bioacid change and bioacid circulation. The biliary limb, when we talk about renal gastric bypass, will receive the bioacids directly without competing with food. So this contact with bioacids has an antimicrobial effect. And also we have some important changes in gut microbiota. That is the focus of my presentation. So what we have found after bariatric surgery is that patients submitted to bariatric surgery, they will present after surgery increased gene richness, also increased abundance of certain species that have a correlation with healthier microbiota and a healthier situation, like they are going to be with less hunger, they are going to be less hunger and healthier. And they also will have lower lipopolysaccharides circulating. That is a marker of toxemia, and it will lead to some inflammation. So decreasing lipopolysaccharide is better for their health. And the increase of production in GLP-1 and PYY after bariatric surgery due to microbial change will also achieve central nervous system and decreasing the reward with high caloric foods, for example, high fat foods and high sugar foods, ultra processed foods, and they also will feel less satiety. Increased satiety, sorry, less hunger. So another effect of GLP-1, when GLP-1 is released, that is also going to be the release of GLP-2. And GLP-2 has a specific impact in the enterocyte. So GLP-2 will increase the tight junction proteins, and it will increase the gut improve the gut microbiota permeability. So patients are going to be absorbing less toxins from the diet. It also will increase the production of some bacteria such as Akkermansia and Proteobacteria, and they will have a good effect in patients' gastrointestinal tract and also microbiota. GLP-2 also increases the number of enterocytes and villi, and this will increase the uptake of glucose from the enterocytes, and this will lead patients absorbing less calories because the enterocyte is going to take more calories from the diet. Papers that have evaluated Renal gastric bypass patients and sleeve gastrectomy patients and microbiota found difference in both procedures. However, renal gastric bypass patients presented a higher change and a higher quantity of healthy bacteria after bariatric surgery. Well, talking about specifically about gut microbiota and weight regain after bariatric surgery, this is a research conducted by myself and some colleagues. We found that after surgery, when we compare patients in the preoperative moment, patients that had renal gastric bypass and have a healthy weight, and patients that presented weight regain, and all of these two groups of post-op patients were they had more than 5 years of surgery. We found some difference among the groups. There is an increased Proteobacteria among the weight regain population, increased bacteroidetes among obese population, the pre-op moment. And also we found other difference, increased Akkermansia among patients that didn't present weight regain. By the end, we find this interesting graphic showing the difference between patients in the pre-op moment and patients in the post-op moment. And as you can see here, there is a change in the abundance of bacteria depending on the group, and the Akkermansia is highly increased among non-weight regain population. ASMB53 is increased among weight regain population, and I'm going to talk about the results in the next slide. So the key point of this study is that there is a big difference between post-op patients and pre-op patients. There is a genera that are inherent to renal gastric bypass, and it seems that this microbiota has a positive impact in patients' metabolism. So we find these 4 bacteria that were more common in the post-op patients Both groups, randomized gastric bypass with healthy weight and with weight regain, they have increased microbiome richness. So even with weight regain, patients presented a different microbiome when we compare with the pre-op patients. The no-weight regain group, they had genera of bacteria that had a correlation with weight loss. This bacteria produces is able to produce a lot of short-chain fat acids, and the production of short-chain fat acids will increase GLP-1, which will have all of this impact, decreasing hunger, increasing satiety, and improving the microbiome. And this SMB53, that this is a species that was found among weight regain population, it is found among patients that have weight to regain, or that patients that are gaining weight and having a habit of ingesting a low fiber diet. Patients that didn't present weight regain also had a higher quantity of Akkermansia group that is related to a healthier microbiota. And we also found that some anatomical barriers due to surgery may prevent the proliferation of bacteria related to weight regain, because we found that microbiota among patients that had randomized gastric bypass are totally different from patients that are in the pre-op moment. Talking about weight regain and microbiota, we are talking about the change that comes along with the surgery. However, I would like to highlight some eating habits that can have an impact on our microbiota. We know that some macronutrients are important and they have effects in our microbiome, and some health effects or unhealth effects. So fiber, carbohydrates, protein, unsaturated fats, and polyphenols, they have a positive effect in our microbiota, decreasing inflammation, decreasing body mass index, decreasing inflammation, increasing satiety, helping weight loss. However, saturated fats, they have an indirect modulation in the gut microbiota, and they can increase firmicutes, proteobacteria, leading to some endotoxemia, increasing body weight and adiposity. So I know that protein is a key point for this population. We are concerned about lean mass preservation and satiety. However, including fibers, pre and probiotics, and good carbohydrate and saturated fats also should comes along with this concern with protein when we talk about patients' eating habits. So as a conclusion, bariatric surgery leads to change in microbiota. These changes have an effect in weight loss and weight maintenance. Diet components can contribute to a healthier microbiota. Nutritional advice should extend beyond protein intake, and further studies including pre-probiotics and fiber intake with bariatric population are needed. Some take-home messages: bariatric surgery leads to microbiome richness. However, keeping this microbiome richness in a long term is challenging and depends on diet and habits. Protein is a key point for bariatric population, and patients are submitted to a very low-calorie diet. We know that it is important for them. But this very low-calorie diet is probably poor in fiber and polyphenols, which are important for their microbiota health in the long term. So increasing fiber, pre and probiotics, and within the diet, polyphenols may help patients to maintain a healthier microbiota. We deal also with some bias because we cannot control diets very well with other supplements. Medication can interfere, the antibiotics can interfere in microbiota, alcohol intake, stress, physical activity. All of these are some bias that sometimes interfere in the results when we are talking about microbiota among individuals. We know also that some good, healthy foods will have a healthy impact in our gut microbiota and a healthy impact in our brain. By the other way, unhealthy food also have an unhealthy effect in our microbiota and will lead to some inflammation in our brain. So living with that is also important. I would like to thank you.
Thank you very much, Sylvia. That was excellent. Thank you for simplifying it. I'm sure many would agree it's not the easiest of specialties to absorb and understand. I think we should head to our expert panel and perhaps any questions from the forum as well.
Yeah, so I obviously want to introduce the panel. So that's Helen Parrott, who's a GP, general practitioner, co-author with me on the BOMS guidelines, very interested in bariatric surgery and obesity, and an academic as well. And then also Ken Clare, who is also a good friend of mine. I've known Ken for years. I think he was the first patient advocate ever from the courses we were teaching on many years ago. So Ken lives with obesity, but he's also got a background in mental health nursing. He's been a bariatric nurse specialist. He set up WLS Info, I think one of the largest discussion forums, and also chairs ESO and the European Coalition of People Living with Obesity, I think it stands for. So what I want to do in this is actually bring Helen and Ken very much into the discussions, obviously bringing back the speakers as well. But I want it to be quite an interactive discussion, reflecting the patient's view, general practitioner's view, what we can do to work together, and also just really emphasising what brilliant presentations from 4 dietitians. So that's absolutely fantastic. So I'm going to try and stick with the order of the presentations, but there will definitely be overlap. And I think certainly Sylvia's talk at the end brought back the carbohydrate and protein and those dynamics. But starting off with the protein, I think one of the issues I have as a dietitian is that some patients are very aware, some patients are not aware at all. Those that are very aware can be having protein to the detriment of anything else in the diet. So I'm just thinking, Ken, I know it's quite a topic for patients. So what comes up on the patient forums? What's people's experiences? What do you find?
Thank you, Mary. I thought it was an excellent presentation. And one of the questions that came for me, that historically we've encouraged people to take the protein through food. And I think the presentation was to take some in supplement as well. And I think that that's an issue. And I think the other thing that's currently happening in the UK are that people are finding it difficult to afford protein, particularly with a lot of people in food poverty.
So Violeta, do you want to respond to that? How you do get around that as a dietitian?
Yes, thank you for your comment, Ken. That's true. Here we have a public health system where protein is supplied to all of them, specifically to gastric bypass though, just because we recommend them to everywhere, but it is included only for bypass since there is a segment that is bypassed. So clinically seems to be more relevant, but we recommend them to all of them. So we include the supplements into the follow-up periodically up to 1 year. And we also, because adherence is not properly or very well managed in all of them, we definitely encourage food high in protein, like mostly vegetal sources of protein, like the legumes. We have here access to a lot of healthy veggie protein from the Mediterranean food and Mediterranean diet, and we try to encourage that. We try to encourage this switch of the diet before surgery in these support groups or information groups of patients undergoing surgery, so we can kind of understand what's going to come up next. Thank you, Ken.
And how do you get around the fact that protein foods increase satiety, especially if it's food rather than actually a supplement? So how do we get around that? Because obviously you mentioned that it's not just the protein, it's actually the energy intake that's important. So sometimes I find that people taking so many supplements and protein waters, that the calorie intake is so low. So how do we balance that?
Well, it's true. We encourage, that's why the supplements make sense. We can take and encourage them to drink in the middle of the day, like a snack, like a half afternoon snack, or also the unflavored ones can be added to veggies, soup or clear purees, right at the beginning of the introduction of solid foods. But we encourage to make room for veggie and protein and encourage less, mostly at the beginning, the intake of carbo as starches. We do encourage fruit also, and even nuts, to try to manage with all the food groups. But veggies are encouraged since the week 3, like a whole. And that is how we could manage the bariatric plate.
And bringing Helen into it, because I noticed that a question has come up about protein, is that certainly in the UK, when we have nutrition supplements, they're very much for people with malnutrition who need to gain weight. So we tend to recommend for the protein more meal replacement sort of drinks. But Helen, one of the questions is do you see a day when protein would be prescribed on the NHS for people post-bariatric surgery?
That's an awful question to ask me, is the first thing to say. So I don't know is the honest answer. I think at the moment in general practice, the knowledge around post-bariatric surgery or bariatric surgery nutrition is so low, it's not going to be anytime soon. So I think it's getting the supplements and including protein across the board better. It's not just protein, it's everything. In terms of malnutrition, I mean, general practice, there was historically a lot of the supplements were prescribed, I think, too much and inappropriately, and they were costing people a lot of money to the NHS. So there was a real this is years ago, sort of cut back on those and really trying to keep them more structured and targeting the right people and giving them in the right way, and lots of education. So I suspect there might be a little bit of a reluctance, a bit of concern with people if we tried to introduce that, but this is a bit of guesswork because I don't know, in all honesty. But yeah, and with the NHS, obviously there's so many strains and stress on the NHS at the moment, it's not a good moment in time anyway. So yeah, that's probably my answer.
Yeah, so while you're still there, Helen, is that obviously Julie gave an excellent presentation about blood monitoring and blood tests and that. And within the UK, normally bariatric surgery, the patients are followed up within the bariatric centre for 2 years and then discharged back to the general practitioner. So how confident do you feel about the general practitioners then taking over the monitoring afterwards and being able to act on the blood results that are actually found?
So in a word, I think you'll know my answer to this. Unconfident. So I mean, certainly anecdotally, and we did a study very recently looking at routinely collected data in general practice, which suggested that less than 5% of patients have their nutritional blood screening done and supplements prescribed. So yeah, and I mean, saying talking to my colleagues, there's a huge lack of education amongst GPs in this area. Really, it's a real research need and clinical need. So yeah, I suspect very few people are having annual reviews and having a clinician checking every year on what they're doing, what they're taking, and are they having their supplements, not having their bloods tested, which obviously is a big concern. On that note, actually, I wanted to ask a question about protein and aging, because obviously I see patients, years down the line post-surgery, quite often haven't had any follow-up for years. And obviously you can get give people protein supplements for amount of time. Maybe it'll become a lifelong feature, I don't know, but at the moment it's not. I mean, now we're going to have a population who are getting older who've had bariatric surgery. Do we need to be more concerned about those people? Is there more we need to be doing for that population?
Julie,
do
do
you
want
that questions too?
I just wondering also, Julie, do you want to come in, because you said that you're doing some work around that as well?
To restate that question?
Should I, or do you want to? I was just thinking about people, aging population who've had bariatric surgery and protein requirements. My experience as a GP is quite often seeing people who've had no follow-up, or they've been lost to follow-up many years down the line with multiple nutritional deficiencies. And I'm just thinking, now we're going to start having population who are aging with bariatric surgery. Is there an increased need in that population? Do we need to be doing even more for them, particularly regards to protein because of the aging?
I think it's a very interesting question, because I would assume that, I don't know if it would necessarily be more in terms of actual quantity, but for our patients. But yes, if you took the two populations apart, the more aging and then bariatric surgery, so there is going to be a confluence of needs. And again, I would assume definitely the protein needs are going to be greater than, say, healthy, even some of the unhealthy people in our population. The problem I see with protein is that, we do recommend that early on. And in the US in particular, our follow-up depends on patient, accountability. And so it seems that many times patients get, or they hear, they attend the visits and they get the first part of the education, like the first half of the year, maybe even a little more. But what they're getting is the emphasis on protein. And then they miss the part where you need the carbohydrates to help the protein function, at its best. And so I do think we're kind of in a need for a balance, with the whole protein component. I would hate to get our elderly population who've had bariatric surgery only consuming protein again. So.
Yeah, Sylvia, do you want to comment on that? Because I think you made that point quite nicely in your presentation about it's actually the balance. Protein is important, but it's also getting that balance of the diet, isn't it?
Yes, I would like to add some comments. Besides, carbohydrates are very important. One point that I think is important to be highlighted is that patients, most of the time, they make a confusion between the weight of the food and the protein content. So when you talk about 60 grams of protein a day, it doesn't mean that you're going to eat a beef of 60 grams. So we should highlight that it is difficult sometimes to achieve the minimal quantity, as Violeta rightly told us. And so sometimes supplements are very important, mainly in the first 6 months that they are probably losing muscle mass, a big quantity of muscle mass. And the supplements, most of the time, they have higher quantity of leucine, which Violeta told us that is very important to keep muscle mass. So sometimes it is difficult. You do not use in the first year the protein supplement, because it will help patients to achieve, like 1 scoop of whey will have 20 grams of protein, so they will achieve 60 grams earlier. Another thing that I was thinking about, like putting all together with my presentation, is that when we are talking about microbiota, pre and probiotics and saturated fat, if we increase a lot of like meat and food with saturated fat, we are going to change microbiota. And when we use lean sources of protein and like whey protein that doesn't have most of the time saturated fat, we are going to improve the microbiota. So it's another way of thinking about food and weight loss and weight maintenance in the long term. Thank you.
And then Laura did an excellent presentation about the supplements and the difficulties in patients getting supplements and also being able to adhere to them. And I know, Ken, this is a subject very close to your heart, and obviously with Helen, with her role as prescriber. So Ken, what questions have you got for Laura, and what things come up on the patient forums?
I was just, the point I'd like to make is it strikes me from the conversation that all the education that we do with patients leading up to bariatric surgery stops the day of bariatric surgery generally, and that there's a long-term, lifelong need for re-education. And I guess we'd call it revalidation if we were talking about professionals, but obviously it's not. In terms of vitamins, I thought that Laura made some excellent points, and I see the difference with my European involvement. The people in the Netherlands and Germany and in the US are all a lot more happy to pay for vitamins than people in the UK. And what's happening now in the UK is that the shift of cost is being moved from the GP primary healthcare budget or whatever it is to the patient. It hasn't happened completely, but it is happening. I'll stop there.
Helen, do you want to make any comments on that? I mean, I know that certainly for BOMs, we've classed access to vitamins and minerals as actually treatment. It's actually not something that's just an add-on, that's actually an essential part of treatment. And I do know that where I live in Yorkshire, the Commission is really good about supporting people who've had bariatric surgery to access supplements, but I know that's not true across the country. So Helen, what would be your observations, and what do you think we could do more to support patients?
So I'm similar to you, that I haven't had problems with this, but I certainly know colleagues who, so in the UK, we have clinical commissioning groups at the moment, it's all changing, but at the moment oversee practices, particularly sort of the commissioning of services and the payments. And some of them in the UK do have almost a blanket ban on supplements, but that's come historically, I think, more from patients who come wanting a bit of a pick-me-up. And again, it's a lack of education that this is a medical requirement because of a procedure people have had. So I certainly know colleagues who I've given presentations, and I almost always will get a GP saying, but my CCG won't let me prescribe supplements. So it's definitely an issue, and it's definitely something we need to do education-wise. I mean, my concern with over-the-counter is the health inequalities, which Ken mentioned. You know, that's a really big concern from my perspective, but also that people won't buy the right thing. You know, if it's over the counter, if there's a huge range, they might not have the right content. It's difficult for me as a GP, to be quite honest, have time or to necessarily be able to check for a patient, and most GPs won't have that knowledge anyway. And people naturally will go for the cheapest, particularly again back to health inequalities, and that probably won't have the right content in it. So it does worry me, and Ken's right, things are moving towards people taking more responsibility, which is really correct in many ways. Actually, we've been a little bit paternalistic, but there's with everything, there's a balance to meet, isn't there? And I'm not sure this is going the right way at the moment.
Laura, in the Netherlands, I think you said that people might be able to move the costs to the insurance. How does it work out in the Netherlands?
Well, in the Netherlands, patients pay for the multivitamin supplementation themselves. So they have to buy them online or in the store. And if they have like deficiencies for which they are treated, then these treatments are insured by the insurance companies. So that is also why some patients think, I don't need to take my supplements because then it will cost money for me. But when I have deficiencies, the insurance company will pay my treatment. So that is also, I think, a really important issue that we have to take into account in the patient education, that we have to prevent deficiencies and not wait for a deficiency to occur because patients cannot afford to buy decent supplementation.
How are supplements covered in other countries?
Well, in the US, it sounds very similar. Patients are responsible for purchasing their own supplements. And if they do have a deficiency, most times, not all times, but most times insurance will cover the cost. However, for something like vitamin D, if it's available over the counter, some policies, some providers do not cover that. One of the things I just wanted to say quickly is I started thinking that our patients don't understand what a deficiency is and what it can do to their body. And so over the past year or so, I've really been incorporating that into my education with them. And I feel like I've seen a difference. I feel like now the only reason patients don't take their vitamins, because I tell them about the patients I'm seeing that are having issues with their teeth and, you know, decay and loss. But I think now it is more so a cost deterrent. But the bariatric formulated vitamins are much more affordable. So I then try to have them do a comparison of cost and let them know also that they had their stomach removed a portion, and that stomach is not going to grow back in 2 years, 10 years, 20 years. It's going to accommodate and stretch a little bit, but it's not going to grow back. So why would they think they can stop taking their vitamins? It just doesn't make sense.
Sylvia and Violeta, have you got your own experiences to add to that?
And in Brazil, we also do not have all vitamins covered by the health, the public service. Sometimes they cover, sometimes not, but there's not one specific formulation for bariatric population. Most of the time they will have to pay for their vitamins. And we also have a difficulty in having specific formulation for bariatric patients due to laws, like the law in Brazil doesn't need, and we doesn't have a high quantity of vitamins and minerals, the same multivitamin. So we have to deal with like taking multiple pills per day. That is another, it's challenging, but we are improving little by little, I guess. By the time it is going to improve. One patient have a deficiency, I cannot say that the insurance is going to pay for that, just if it's going to be like intravenous iron supplementation or B12, that is not expensive, actually just iron, but B12 is not. What I truly believe is that we have to be better in teaching patients to take multivitamins as a prevention, even if it is going to be like a cost. Before surgery, we should tell patients you're going to spend a quantity of money with multivitamin every month, because if you do not do that, you're going to have deficiency, and it is going to be even you're going to spend more money, or you're going to lose your quality of life. That's something that you don't want in bariatric surgery. You want quality of life, patients thinner and happier and with energy, not because, as Julie Parrott told us, patients are feeling bad, and sometimes they are not anemia, but they have other signs and symptoms of nutritional deficiencies that are going to interfere in their behavior and their quality of life. So it is, we should make it clear.
Well, here they are covered as a single vitamin or mineral. Of course, if they need, if the deficiency is severe, we inpatient them, we take them in, so to infuse whatever vitamin or mineral, IV, or and also they get monthly the intramuscular B12, and we refer them to the PCP to do that. So they also have the opportunity, well, that was before pandemic, to go to the PCP and have the monthly controls of weight with the nurse educator generally. But we do cover the vitamin and mineral independently, not the all in one pill. But sometimes, even when they are, covered, sometimes they don't pick it from, they don't pick them from the pharmacy. So that's also a thing that, claim our attention. And as Julie did, we included a comprehensive and quality information pre-operatively and during the follow-ups group sessions to encourage this adherence.
There's a comment from Susie Benny in the chat box, and Susie is a patient advocate based in Ireland, and so probably can seek Laura's views on this, because Susie's put down that here in the patient support groups that many patients do have a great understanding what's needed, but they don't always know what to take and when. So then they're quite shocked to find they're deficient. They've been told they're not compliant, which is a word we don't really tend to like, because but the patient doesn't necessarily know what they should be taking and when to do it. So Laura, what can we do to actually improve our communications with patients and make sure we actually have got it at the right level?
Yeah, that's indeed a very important issue that we also found out from our survey. And I think during the medical consultation, at least in the Netherlands, patients are indeed told to take their supplements, but it just isn't enough time to really educate them on how to take them and when to take them, and if they have any questions. So what we do in the Netherlands is that the dietitian takes this part of the education. So not the medical doctor, but a dietitian does the patient education. But I think what we also need to do is to not only mention it once before surgery, because they get an information overload before surgery. So we have to repeat it every single time when we see our patients, not only before surgery, but during every medical consultation afterwards. And I think what we also need to do is to make information and results from, for example, this kind of survey studies, we have to make them available for patients as well, because we publish our studies generally in scientific journals, but patients do not read these journals. So we have to find a way to make our results or information from our very important studies also available to the patients, maybe in infographics or social media. So I think we need to improve in that way, the patient education in that way as well.
Thank you. And Helen, you've your hand up.
Yeah, do you mind? I'm going to ask a slightly controversial question, but I'd just be interested if it is slightly UK oriented. So in the UK, we have certain patient groups who have free prescriptions, people with chronic conditions like type 1 diabetes. I can't think of the others at the moment, but many other conditions as well. And I was just wondering what people think that actually, since this is a procedure that's been carried out by the medical world, by the medical professionals, whether actually is something that we ought to be providing people with, given we've carried out this procedure on people. It's a little bit controversial, so feel free not to answer.
My view, I do believe that people should have access to vitamins and minerals. They might choose to buy others or buy their own, but I personally believe that we should be providing them, but that's my personal view. Any other comments about that?
Ken's got his hand up.
Oh, Ken, yeah, missed the hand bit. Sorry, go on, Ken.
I'm glad we've got Susie on the call. It's a great question. And we've got Vicky Mooney. But it strikes me maybe we should try and do a sort of jointly created survey around the position in several European countries and come up with some and co-create some patient-friendly information we could distribute as a result of that. I don't know if there's an appetite for that.
Would it just be European, Ken? Because we've got Julie from the US, we've got Sylvia from Brazil. Would we want to actually open it more globally?
You know, I've got global aspirations. And the other thing is, I'm a 60-plus-year-old, 20 years since bariatric surgery. So all this long-term stuff's got an interest for me.
I feel like in the US, we do a pretty good job actually in our education, making sure that patients understand what specific vitamins and timing, especially with calcium and iron. So, and I think there's probably surveys that have already been done here, but it's a good idea.
Yeah. And I know time's marching on, but I did notice a question which I thought was very relevant. And again, that's from Vicky Mooney, who again is a patient advocate, and trying to find it. But I think in summary, it's more about protein we know is important, but sometimes especially in the early stages post-bariatric surgery, some of the good sources of protein can be quite difficult to manage, such as chicken and that. And how, if you're looking at, say, vegan sources of protein, how would a patient know that it's actually a good source of quality, you know, it's a good protein quality? I think even as a dietitian, it can be quite hard to determine that. So any advice there?
Well, yes, I am not silent. I think part of this comes into the education sessions, right? And it's true that food labels could add a mark on what it's supposed to be a high quality. But mostly following this high protein veggie, like the list I had in one of my slides, probably we should distribute this or use it as an education tool in our sessions with patients. I think we should ask them, what do they know about it? And try to base the education session based in their own knowledge or preferences or eating habits, etc. Well, I guess sometimes we could get like a frontal label marking saying that is a high quality veggie protein. That could help, I think.
Yeah, it's a hard one, isn't it?
I know. Well, now we're trying to work with the Nutri-Score. Probably we should, you know, improve this tool little by little.
Yeah. So I'm just aware that time's marching on and everyone's giving up their precious time. Just wondered if Ken or Helen have got any final questions at all, or no?
I think from the fourth presentation, which was very educational for me, is the good patient accessible resources about dietary approach for weight maintenance using that. I think that'd be really useful.
Yeah, and I think Sylvie did an excellent job of summarising that and actually bringing carbohydrate and everything else back in, which patients can get so focused on protein. So is there anything that you want to say further about that?
Yes, thank you for the comments. Actually, I was trying to include information about food itself and not just supplements. We are always talking about protein supplements and vitamins and minerals. Sometimes we could think about, using pro and probiotics, like in terms of supplements, could help. We don't know, probably it could help, but we can include pro and probiotics within the diet, like with the yogurts, cheese, pickles. They are all sources of pre and probiotics that can help think more about the food, the fiber, the content of fiber in patients' diet. That is challenging in the first year, actually, but I would like to give this idea of we can deal better with the diet and improve the quality of the diet for the bariatric population to improve microbiota.
Thank you. I'd just like to thank everybody because we've had 4 excellent presentations from 4 excellent dietitians, and it's been fantastic to have Ken as a patient advocate and Helen as general practitioner contributing and making this actually a much wider discussion rather than 4 dietitians plus me just talking about the merits of dietetics and that. So I'd like to hand back to Osama now for the final words.
Thank you very much, Mary. Yeah, once again, thanks for all the speakers. Excellent presentations, slides, very time coordinated. And special thanks to Ken and Helen again for joining us. And Mary, thanks to you. Without you, this wouldn't have been possible, really. So thanks, everyone.
Thank you.
Thank you.
Thank you.
Everyone,
bye.
And take care.
It's good seeing everybody, and I'm just looking forward to meeting you all in person again. So,
hopefully soon.
Yeah, I think I meet Ken at the end of March, possibly.
Indeed, you do, I think.
Yeah, in Darlington. Yeah.
Darlington.
Yes.
We get to all the great gigs, don't we?
Yes. Yeah. Okay. Okay, well, thanks very much. And
Okay, thank you.
yeah,
Thank you. Bye-bye.
bye.